right. Well, I'm going to go ahead and kick off tonight's program. Thank you, everyone, for joining us for the Schwarzman Animal Medical Center's 11th Annual One Health Conference. We are so delighted to welcome two wonderful and highly experienced. It's such an honor to host both Dr. Kathleen Cooney and Dr. Sean Morrison this evening. The topic for this, for all of our programs is graying together the One Health approaches to aging patients. And tonight, the specific topic is on palliative and hospice care models, a focus on the human and animal experience. I'm going to read the bios for both Dr. Cooney and Dr. Morrison, and then we'll be able to kick off their presentations. Dr. Kathleen Cooney is the founder and senior director of medical education at the Companion Animal Euthanasia Training. She has been practicing advanced end-of-life care since 2006. In 2017, she founded the Companion Animal Euthanasia Training Academy, CADA, and is now their Senior Director of Medical Education. And she has owned 3 end-of-life businesses. Dr. Cooney is well known for her work in companion animal euthanasia and has authored 2 books on the subject, along with numerous articles and book chapters. She has collaborated in end-of-life training for the AVMA, AHA, NAVC, IAHPC, and the Fear-Free program. Plus, she is the past president and board member of the International Association for Animal Hospice and Palliative Care. Dr. Cooney is a strong advocate for best practices in all aspects of end-of-life care and speaks nationally and internationally on such topics. She is board certified in animal welfare and is associate director of One Welfare at Colorado State University, where she teaches end-of-life topics in animal welfare. She loves all things old and gray. It is such an honor to welcome you, Dr. Cooney. This is one of my passions as well, is gray muzzles. Dr. R. Sean Morrison is joining us from the Ellen and Howard C. Katz as the professor and chair of the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine of Mount Sinai. He is also co-director of the Patty and J. Baker National Palliative Care Center and director of the National Palliative Care Research Center, national organizations devoted to increasing the evidence base of palliative care in the United States. Nationally, he has served as president and secretary of the American Academy of Hospice and Palliative Medicine. Dr. Morrison is the recipient of numerous awards, including the American Academy of Hospice and Palliative Medicine's PDIA National Leadership Excellence in Research and Visionary Awards, the American Cancer Society's Distinguished Achievement in Cancer and Clinical Research Professor Awards, the American Geriatric Society Outstanding Achievement for Clinical Investigation Award, and the Jacobi Medallion, Mount Sinai's highest recognition. So we are in for a treat this evening. Dr. Morrison has received over $75 million in research funding focused on improving care for seriously ill older adults and their families. His work has appeared in all major peer-reviewed medical journals, including the New England Journal of Medicine, Annals of Internal Medicine, and the Journal of the American Medical Association. He edited the first textbook on geriatric palliative care and has contributed to more than 15 books on the subject of geriatrics and palliative care. As one of the leading figures in the field of palliative medicine, Dr. Morrison has appeared numerous times on television and print to discuss his own research and to comment on matters related to older adults and those with serious illness. Dr. Sean Morrison received the SCB from Brown University and his MD from University of Chicago Pritzker School of Medicine. He completed his residency training at the New York Hospital Cornell Medical Center, followed by his postgraduate fellowship training at Mount Sinai School of Medicine in New York City. He has been at Mount Sinai's faculty since 1995. Please give a warm welcome to both of our speakers. As I hand this off to our two wonderful speakers, I just want to remind you that there is a chat box there. About midway through, you'll be able to put your questions in. We'll address the questions at the end of the session. Also, you'll be receiving a link that you need to fill out in order to get CE credit. For those of you, those veterinarians who are looking to get CE credit, please remember to fill out that form. And I will go ahead and take myself off and kick it off to Dr. Cooney. Thank you so much.
Perfect. Thank you. And while we do, I just want to say, Dr. Morrison, listening to your background, I am reminded how far we have yet to go for animal hospice. You know, with all of the opportunities and awards and things, we have a long way to go. And I'm very excited for what the future holds. You're leading the way. All right, what we'd like to do is begin our time together by just doing a little bit more introduction on our background, and then Dr. Morrison is going to talk first about human hospice care models, and then I will move into the animal models and the experience, and then we're going to bring it back around to some conversation with all of you. So we're going to start by defining palliative and hospice care, appreciate the key differences and, of course, similarities, and evaluate the potential for a One Health approach to enhance quality of life for all patients. This is the first time that I have been knowing about an opportunity in the One Health space for hospice in the human side and the animal side. I'm so thrilled to the Schwarzman Animal Medical Center for bringing this together and certainly inviting me to participate. I'm absolutely thrilled. We have so many important things to talk about tonight. Just a little bit more context behind my background. Just wanted to share that when I first got into the end-of-life space, it was back in 2006. I was in private practice for 2 years, graduated Colorado State 2004, and found my calling in home euthanasia, specifically in 2006. And it was through a need and even the desire within the community to start to help to support these patients more as they're approaching the end of life with hospice and palliative care versus just being called out at the last hour for something like euthanasia, really was awoken to this opportunity to provide more palliative care and then, of course, learn about hospice. So when I actually started my home euthanasia service back in 2006, hospice was still not really talked about a whole lot in vet med. So fortunately, there's some history that started to change and we got more opportunity within hospice and palliative care, and I'll talk about that here in a moment. But just wanted to share that my background started as home euthanasia until I really found the need for hospice and palliative care. And as we heard already with my bio, yes, I am with the Companion Animal Euthanasia Training Academy. And why that's important tonight is because it's an educational division of Lap of Love. Lap of Love is the largest in-home pet euthanasia and hospice service in the United States, potentially the world. And so Lap of Love is very well versed in hospice and palliative care. And again, just thrilled to be here tonight with all of you. So with that, I'd like to turn it over to Dr. Morrison to take us into more of the human hospice side of things.
Good evening, everybody. And I just wanted to echo Dr. Cooney's thanks for allowing me to be here and to present. It is, for me, an unusual opportunity and an unusual audience. So I'm really thrilled to be here with you. What I was going to do in just a little short period of time is walk all of us through the origins of palliative care in the United States, what it is, how it differs from hospice, and some of the outcomes that we see when palliative care is provided at the same time as other disease-directed treatments for people living with serious illness. Next slide, please, Kath. Oh, neither Dr. Cooney nor I have any financial disclosures. Onwards. So I want to take us back to about the 11th century, and this is a representation of one of the first hospices. Hospice was started by nuns back in the 11th century and was established to take care of sick and dying travelers who were coming to or going from Jerusalem during the periods of the Crusades. And hospice thrived for about 300 years in this model and then faded away. And so I'm going to skip 2,000 years of hospice development and bring you up to the present. Next slide, please, Kathy. So the modern hospice and the modern hospice movement began because of the work of one pretty remarkable woman, and that is Cicely Saunders, who was a nurse, social worker, and a doctor, all rolled into one. Dame Cicely was caring for patients both during World War II and subsequently after, and recognized how poorly people near the end of their lives were being treated. Unnecessary pain, other symptoms, spiritual distress, emotional distress. And Dame Cicely founded the first modern hospice in London, St. Christopher's Hospice. The picture is there. And for those of you who are interested, St. Christopher's still exists, is thriving. There's also a Cicely Saunders Research Institute at King's University in London, and anybody can, if you're in London, I encourage you to take a look at it. It really is modern history. Hospice, next slide, please. From St. Christopher's, hospice made its way across the Atlantic. First to the Royal Victoria Hospital in Montreal, where a urological surgeon, Balfour Mount, had met Dame Cicely and brought hospice back to North America. Subsequently, Florence Wald, who was the Dean of Nursing at Yale University, also encountered Dame Cicely and established the Connecticut Hospice, which is the small building down in the bottom right. The difference between the Royal Vic and Connecticut Hospice was in two steps. First, the Royal Vic was affiliated with McGill University, so it was established into the academic medical center, and it was primarily focused on inpatient care. Connecticut Hospice, on the other hand, stood alone and was primarily focused on delivering care in the home. Next slide, please. Hospice in the United States became formalized under the Medicare hospice benefit in 1982 as a result of research that had been done, which essentially demonstrated that hospice care was less expensive than traditional health care. The Medicare hospice benefit was passed, and the Medicare hospice benefit has remained relatively unchanged for the past 43 years. And in some respects, it's problematic, and I will talk a little bit about why that is in a moment. First of all, to be eligible for hospice, you have to have a prognosis of 6 months or less if the disease follows its usual course as certified by 2 physicians. So essentially, you have to have a very limited life expectancy. You have to give up life-prolonging or curative treatments. These can include chemotherapy, radiation therapy, new immunotherapies, and you have to agree to give up hospitalizations, your Medicare Part A benefit. And under statute, 80% of the hospice's total service time must be provided in the home. Next slide, please. What does it cover? It's a pretty extensive benefit. It provides coverage for all disease-related medications to provide comfort. So those are all paid for, and in many hospices, delivered right to your door. You have access to a team of nurses, social workers, chaplains, and physicians, 24 hours a day, 7 days a week. You are eligible for home health service support for your personal care needs. On average, that's about 20 hours per week, or 4 hours Monday through Friday. And unlike any other medical coverage particularly under Medicare, your family is eligible for bereavement support. Next slide, Kathy. So one would think with all of those benefits, most of us would want hospice at the end of our lives. And yet, since the Medicare hospice benefit was initiated, only about half Americans opt to access their benefit. And it is a benefit. It's something we've all paid for in our taxes. And it's available to all of us who have Medicare. And there are three reasons for that. The first is hospice still remains relatively siloed from routine medical care. And hospice grew up as a counter-cultural movement in the United States. It was a response to unnecessary, in many instances, burdensome medical treatments. And it has never yet fully integrated itself into routine medical care. The second is that in order to access hospice, you have to say and self-recognize that you're dying and that you are comfortable with that. And whereas many of us, what I like to call the worried well, hypothetically think about what we would want at the end of our lives, the reality is most patients, and most of my patients, would much rather continue living than dying, and that life, and in many respects, no matter what that looks like to people, is better than the alternative. And so this, what people say, denial of death, often is a major barrier to accessing the Medicare hospice benefit. Sorry, lost my train of thought. And then the third reason is that it requires somebody to both give up potentially useful therapies, particularly modern immunotherapies, and to be able to prognosticate when you have 6 months to live. You would think that's very easy, but it's actually very difficult. Doctors, we're very good at prognosticating within a few days or a month of death. We're terrible at prognosticating 6 months. Next slide, please. So we trundled along from 1982 with the Medicare hospice benefit up until the mid-1990s, when three things happened in America. The first was the right to die movement and the rise of the assisted suicide movement, epitomized by Jack Kevorkian, who would drive around in his VW bus, literally, and hook up patients to his euthanasia machine, shown here in the top left. Dr. Kevorkian, by the way, was a pathologist who actually never treated a living patient up until he became a euthanasia advocate. The second thing that happened in the 1990s was the publication of the support study, which was a $27 million study funded by the Robert Wood Johnson Foundation that was designed to look at care for people with serious illness in the United States. And what hit the front page of our local paper, the New York Times, was the appalling amount of pain, distress, suffering, care in conflict with patient preferences that was happening in 5 of our best teaching hospitals. And finally, in the 1990s, we had the AIDS epidemic. And the AIDS epidemic brought into all of our lives a tremendous amount of pain and suffering that we just didn't have treatments for. And in fact, one of the reasons that I moved my career into palliative care was because of the inability to treat the suffering of patients living with AIDS and HIV in New York City in the 1990s. Next slide, please. So as a result of those three, sorry, folks, ever since I've had COVID, I have word finding difficulty and I can't find the word I want. So because of those three events, many of us in academic medicine began to think, why should good pain and symptom management, high quality care for people living with serious illness, be confined to those who are dying? That is, those under the hospice benefit. Why can't people living with serious illness get access to high quality pain and symptom care, high quality communication about their wishes, goals of care, and what treatments they would want, and importantly, family support. And so from that idea, modern palliative care in the United States developed. And palliative care in 2025 is defined as specialized medical care for people with serious illness. It provides patients with relief from the symptoms of pain, the stress of a serious illness, whatever the diagnosis, and it improves quality of life for both the patient and the family. Next slide, please. It's provided, like hospice, by a team of doctors, nurses, and other specialists who work with the patient's own doctor to provide an added layer of support. And importantly, it's appropriate at any age, from neonates all the way through centenarians, and at any stage in a serious illness, and it is provided concurrently with all other appropriate medical treatments. Next slide, please. So if you think about it, what we used to have was this idea that you had a disease, and at some point you were recognized as dying, and as one of my colleagues says, you're thrown over the wall into hospice. Under palliative care, as a disease progresses, there's a gradual trade-off between those treatments focused on comfort, those focused on disease, and for people who do recognize they're dying and for whom there is a stable prognosis, or you're able to make a prognosis, hospice comes in right at the end of life. Next slide, please. So let me give you a picture of what palliative care looks like. This is one of our patients. Her name is Debbie. I have permission to use this picture. She's 52 years old. She's a mother. She's a grandmother. She owns her own beauty salon. And we, about 10 years ago, she developed multiple myeloma, had a very successful bone marrow transplant, but as a result of that, had severe nerve pain, tremendous fatigue, stopped working, essentially stopped living. Next slide, please, Kathy. And in fact, her life was disabling pain because of chemotherapy side effects. She became depressed. She experienced functional decline. She couldn't work. She was socially isolated and experienced tremendous spiritual suffering. Her family, as you can imagine, both her kids and grandkids, were very distressed. And she had multiple 911 calls for pain crises, 3 emergency department visits, 3 hospitalizations. And when we met her, she was absolutely devastated because she was accused of being a drug addict, seeking opioids by the emergency staff. We saw her, we got her pain under control. We addressed her family needs. She was able to resume her work. She started going back to church. She had 24/7 phone access to our team. She's had an ongoing relationship with our palliative care and her hematology team for over 10 years. We now just see her twice a year. She got support from our social worker and our chaplain, and she has had no 911 calls and 0 ED visits in the past 10 years. Next slide, please. And just finally, what happens when you provide palliative care at the same time as traditional disease-directed care? Well, if you have cancer, you get a better quality of life, you become less depressed, you're much less likely to be admitted to the hospital, and you'll live longer, on average 2 months longer, which, by the way, was the survival advantage of the first chemotherapy regimen for lung cancer. So you feel better and you'll live longer. Next slide, please. And this is my last slide. So what does palliative care do? It improves value. Patients' symptoms improve, their quality of life gets better, they live longer, their family is more satisfied. For people who die, family bereavement outcomes are better, and doctors actually are more satisfied with the care that they can provide. And at the same time, it's one of the few things in medicine that it not only improves quality, but does so with reduced costs. Hospital costs are decreased primarily because people don't need to be admitted, and they don't need to go into the emergency department. They don't get readmitted, and unnecessary laboratory imaging and pharmaceutical costs all go away. I think it's yours now, Dr. Cooney.
Thank you. You know, I love this slide in particular, Dr. Morrison, because it applies so beautifully to human and animals. I could have created this slide myself for vet med. While we don't have a lot of data for showing us how the costs are reduced and decreased hospitalization, everything on the left is very applicable. So it's blends beautifully for my next section. So everyone, I'm going to move in to talk now about what is animal hospice, the categories of care, and the different models that we have out there, I would say, in modern vet med. When you think of animal hospice, my guess is that you are thinking just what Dr. Morrison shared with us, that it is a terminal time of life. We have reached the end, but it's not well defined on how long that time is. That is a variance from human medicine. It is really kind of defined in our world as a philosophy of care, that it begins when it's evident that death is coming, whether or not that is age-related changes that are extremely advanced, or we do have a terminal life-limiting illness. We believe that we are now entering into a hospice time. Because we do not have the financial benefits through something like Medicare, then we can say that this could be anywhere from a month to 6 months. I think often these days we lean on close to a month to 3 months, kind of on average. But it does focus on the emotional and physical support of the dying pet and the emotional support for caregivers. So again, really good parallel there on the human side. And that we're focusing on helping these animals to live life to the fullest, to try to minimize symptoms and keep them comfortable, keep their daily quality of life very, very high, and to safely make preparations then for death itself. So it's a lot of communication, a lot of education about what the dying process looks like, because so many people have not walked the journey with an animal before, especially if they've euthanized right away in the face of an illness. But what's important here, I think, is this last statement as well, where it says that death may come through hospice-supported natural death or by euthanasia if deemed necessary by all involved. And why this is so key is because it was quite a few years ago that the International Association for Animal Hospice and Palliative Care Association was formed, and it was because Dr. Amir Shanan wanted to make sure that we didn't look at euthanasia as some sort of failure, because that is so common in vet med, and that we don't necessarily always have to be trying to achieve a hospice-supported natural death. In other words, it's more about the journey, getting to those final days of life. And if our patient should die peacefully and naturally on their own, wonderful. That's of course going to be with really good palliative care. But if we do make the choice for euthanasia, then that is perfectly acceptable. And again, not necessarily a failure. So I wanted to take a moment to share just a brief history of animal hospice. And I think it's interesting that it's the 1980s when animal end of life started to really take shape. So a lot of parallels there with the human side of things in the United States. But it came from veterinarians looking at what was going on with human hospice and saying, can we do more for animals? And of course, modern medicine is getting better. We have better pain remedies. We have better nutrition support and ways that we can palliate. In 2001, the AVMA, the American Veterinary Medical Association, published the first veterinary hospice guidelines. I also think it's interesting that they have not published guidelines since. They have just been leaning on what other groups like the IHPC and the American Animal Hospital Association have published with, kind of taking things forward. And the AVMA even at one point thought about changing the name of the guidelines from hospice to end of life, because we weren't sure we wanted to use that same term in veterinary medicine. But at this point, I think it's got a substantial stronghold. In 2008, they had the first International Symposium of Veterinary Hospice out at UC Davis in California, brought together a lot of subject matter experts in the space, as many as we had at the time, really kind of bringing first time ever a collective body of experts to talk about veterinary hospice today, as well as the future of it. And this is where there was some, I'll say, conflict or a disagreement about whether or not hospice had to be natural death support or whether or not euthanasia would be, again, equally acceptable. So in 2009, there was a formation of the International Association for Animal Hospice and Palliative Care, which is a multidisciplinary organization. So we have veterinarians and technicians and social workers and anyone really that wants to understand and know more about hospice and palliative care. Then around 2010, there started to be an increase in mobile providers in particular that were going to the home, helping with euthanasia, helping with palliative care, and having more of these kind of hospice conversations and setting the clients up with a lot of education and support and pre-planning for what that death event would look like. 2011, we started to have some hospice books arriving, and in 2013 and 16, we had more hospice care guidelines than what the AVMA had initially put out some 15 years earlier. So in 2013, I believe that's when we had, came out 13. I forget which group it was, but 2016, I think, is when the American Animal Hospital Association and IHPC got together and produced those guidelines. Actually, I think it was the IHPC that had their 2013, and then they had a subsequent edition. 2019 is when we had the formation of the World Veterinary Palliative Medicine Organization. And that is still in existence today, along with the IHPC. The WVPMO is strictly for veterinarians, and it is through this group, as well as with the IHPC, that more than likely we will eventually have a specialty college for veterinary hospice and palliative care. Currently, that does not exist. So the most education that we have out there would be credentialing, like with a certificate program for veterinarians to become certified hospice and palliative care veterinarians through the IHPC, or certified hospice and palliative care technicians, again, through the IHPC. It's about a 125-hour program. That is our upper echelon right now of credentials that you can get in this space. So what are we talking about with categories of care, and how do they parallel with human medicine? Well, we're going to for sure have palliative medicine, non-curative comfort care to hide symptoms. Then we're going to be talking with clients and colleagues about natural death support. So what does it mean to walk that natural dying process? This is not something that we are taught in veterinary school. And Dr. Morrison, I'd be curious as we get into our conversation, as we wrap up, of how much training you got in school as it relates to the dying process. But in veterinary medicine, it's really not much, maybe club activities and things like that. Or if you have someone like me at Colorado State University that would teach it. We have euthanasia as a category of care, meaning that veterinarians would need to know about all aspects of euthanasia, the techniques, where it can be conducted, and how to best support the patient during that procedure. Grief support before, during, and after death. And then body care. This is a big part for us in vet med because we wear a lot of different hats in end of life, including being a bit of the funeral director to help clients to make arrangements. So if it's not the veterinarian, it's certainly the team that is going through what's possible and helping our clients get their wishes met. So to say that one is a hospice veterinarian, they would need to know as much as possible about these 5 different categories, but they might not be well versed, for example, in natural death support, and might then need to refer out to someone else in the community that can walk that journey more effectively. I know many veterinarians that are in the hospice space that do not necessarily know how to palliate and provide comfort for a dying animal in the last potentially like 3 days of life. It is specialty education. A reminder that what we say in hospice is that you always have to have palliative medicine to be a part of that, or palliative care, but you can have palliative care without hospice. That is certainly what Dr. Morrison just shared with us. So when we are working with our clients, our families, we call this the triad of care. We're going to be making sure that we're meeting the needs of our patient, meeting the needs of the client and family who are ultimately going to make the decision of whether or not to palliate and to try to continue on life for as long as possible, or to reach for euthanasia sooner than later. And everyone is a bit different. It will be determinant on whether or not this is the first pet that they have ever worked with through an end-of-life journey, or many, where they might be feeling more empowered and likely to feel successful to carry on with palliative care longer and before reaching for euthanasia earlier. And then, of course, the veterinary team, we want to make sure that they are feeling very balanced and sustained in this work, because they are about to be potentially more challenged than they ever have before. There is a lot that we know goes into caring for a dying patient, and hence probably why veterinary medicine does reach for euthanasia sooner than later in many instances, because we have yet to learn what all the potential are for the drugs out there, and how we can continue on even through natural death. So we have a village that's going to be caring for these animals, because we do not have the infrastructure that human medicine does. We have to rely on others out there in hopes that cost is reasonable and that we're all working collaboratively to make sure that the animal is prevented from a suffering state. And again, the client is informed and feeling empowered to continue on. There's just a lot that we need to take into account. So we do need a village. But the primary four in vet med with hospice will be the client and the family, who will be carrying out the majority of the care. It's not a vast team of doctors and nurses. It is going to be a lot laid on the family, as well as the veterinarian always being the primary director of care, the technician helping to facilitate that care. And then we like to see a mental health professional on the team. They might not be employed by a veterinary hospital, but it's the veterinary team that is directing the client to reach out to a mental health professional as needed, whether or not that's a social worker or a counselor or a psychiatrist and psychologist, many different mental health professional roles. But we like to have someone that we can refer to help when things are getting a bit emotionally challenging. I'll just share before we move quickly into the animal hospice models of care, and a quick case just to share what we're kind of talking about here is this 5-step hospice strategy that was created by Dr. Tammy Shear back in 2011. And this is what all of us in the hospice space follow. This is our true north. And that is when we're having these conversations with clients about the future of their pet, and how close we are to death, we're going to want to understand their psychosocial factors. So previous experiences around walking this journey, or previous experiences with euthanasia, goals of care, and of course their limitations, such as financial limitations and physical limitations. You know, think about the 150-pound Great Dane that's on the 3rd story of the apartment building, and it's going to be difficult with osteosarcoma getting them, down and back up again. So what are those physical limitations too? So we really want to sit back and let the client tell us everything possible about their feelings and goals and concerns, and then we can determine whether or not we're going to actually form a true hospice plan. But before we even do that, we need to educate the client about the disease, what early stages look like, later stages, and signs of crisis. What everybody wants to know about is, what does pain look like? And how can we manage breathing difficulty? We want to make sure that the pet is sleeping well at night. So we are going to educate about the disease to the client. And if the client feels compelled to want to continue on with care versus saying, you know what, we feel like we've reached the time where we want to euthanize, or maybe we'll try something for a week or so and then make that euthanasia decision. If they do want to enroll in a broader care plan, it's going to be highly personalized to that family and to the pet patient. So this is what the veterinarian will create. And then we need to teach them how to apply those care techniques. Technicians are often the ones doing this, unless it's a team of one, which would just be the veterinarian. So teaching the family how to care for the pet, setting up a good communication plan and strategy, And then number 5 is just providing bereavement support all the way through, before, during, and after death. Very pleased to share that with human hospice, we learned early on that, and Dr. Morrison, correct me if I'm wrong, but human hospice emotional support for the bereaved continues 13 months past the death of a loved one. And so we are trying to emulate that more and more in vet med, and even sending, reach out a year later, bereavement cards, and just doing just doing a touch point with those families, letting them know that they're being thought of. So real quick here on the animal hospice models of care, very different from the human side for the most part. We have veterinary teams that are going to be what we call hospital-based. That's what that should say right there, hospital-based. And that's a lovely picture of the Schwarzman Animal Medical Center there in New York City. So it's where the DVM team is based out of the hospital. And then we also have the mobile-based service where it is, again, still DVM-led, but it is not utilizing necessarily the resources of a traditional hospital. And then there's a model that we call case manager managed, which is where we have veterinary technicians or even social workers or sometimes lay people that are trying to be the liaison between the DVM at a hospital and the client in a home. And so they're kind of managing the cases for the veterinarians that may not have a good support team underneath them to do such a thing. And then there are animal hospice sanctuaries out there, different than rescues. These are sanctuaries where the animals will live out the remaining days. These sanctuaries might be pulling in a fair amount of geriatric patients or those that are, deemed terminal, that are reaching the natural end of their life. As you can see here, all 4 models, no matter what, are still going to be DVM led. So it's the veterinarian who is putting together the care plan and making sure that everything is facilitated properly. So I'll close here with Finch before we get into more dialogue. Just an example of an 8-year-old male castrated Doberman, about 85 pounds, that presents at the veterinary clinic for lameness of the right front leg. It is discovered that the sweetheart has osteosarcoma, and now there's going to be a discussion with the family about next steps. Owner is offered the option of attempted cure, or are we going to be looking more towards palliative care with hospice as well? So if the caregiver or client chooses hospice care, then there's going to be a broader conversation to really understand, again, those psychosocial factors, educate about the disease, and then create a personalized care plan. Family wants Finch at home for as much as possible, so that is understood that we might not be going in for a lot more diagnostics at this point. It's just going to be palliative care. And then a team member is going to be assigned for regular communication. So what does that look like for continued care? We're talking typically about technicians or the lead veterinarian themselves, or maybe associate veterinarians that are going to be going to the home and doing that work. They're going to be doing potentially everything from fluids to bandage changes to assessment of pain. And if it's a technician, that they're doing that under what we call indirect supervision. Lots of communication, lots of telemedicine, possibly providing comfort kits so that we have something if Finch goes into a crisis. And then if we do feel it's warranted to do more diagnostics and blood work, that's always a possibility. Medications would be easily refilled if this is a case that is set through a hospital. And then maybe we start to see that quality of life is starting to decline about 4 weeks later. And this particular instance, the family has chosen euthanasia. And very commonly in animal hospice, it's going to be mobile euthanasia that is carried out. So that is a big part of the hospice planning, is how are we going to facilitate euthanasia, which today we know that with research, about 85% of dogs in particular will be euthanized. So 85% for dogs, and we can kind of guess at this point that cats aren't probably too far off from that. And the hospice team will be the ones that help to make all arrangements for aftercare, and they're likely going to have those conversations very early on. All right, that is my information that I wanted to share with you to get us rolling now more towards the shared successes in One Health. And I'm going to go ahead and kind of put all of these up for us, Sean, and maybe let you kind of take it away after you've heard me talk a little bit about animal hospice now too.
Yeah, and I think I hope that you see that there are tremendous similarities, some differences obviously, but tremendous similarities to the care of our seriously ill patients, that include advancing medicine focused on pain and symptom management and support of the family. The idea of ensuring that family members have comfort kits at home and the appropriate knowledge and materials to provide good pain and symptom management, so that our patients can stay at home, and our goal for a peaceful death. I think even for those of us who think that death is hypothetical and not going to come for us, it will at some point, and that our goal should be a peaceful path. A peaceful path rather than one that is difficult and full of suffering. I think the next one's yours.
Absolutely. And I'll just add that I'm so proud of veterinary medicine for giving more and more and more attention to pain, which is in pain management, which is one of the driving forces or reasons behind premature euthanasia, that the more that we can follow what human medicine has done and try to palliate pain at every turn, then if we can do that within veterinary medicine, I certainly consider that a success, and that we can stave off euthanasia longer and continue that human-animal bond for as long as, deemed making sense. So some of the shared challenges that we have here, within veterinary medicine, we don't necessarily have a lot of evidence-based medicine around palliative care, specifically where we could even say with the future development of a college around hospice and palliative care, when we have to amass, do a literary search of everything related to research in this space, we don't actually have a lot. We have more and more coming up because of the advancements of medicine. But when we start to label research as palliative or hospice, then I think we're going to have greater successes. But there's not a lot of research necessarily that's specifically being done in this space. What about for you, Dr. Morrison?
Very similar. I mean, I think we have a larger evidence base than what exists in veterinary medicine, but compared to traditional medical specialties, cancer, cardiovascular disease, we have a very limited evidence base, and it's one of the things that we've been really working on building.
Yeah, absolutely. For us, we have a huge challenge with finances, even with insurance. Insurance will cover a fair amount of what's needed for hospice care. It's not necessarily labeled as such, and benefits do not increase when a veterinarian has deemed this patient to be dying. It's just standard payouts for treatments and procedures as any other time. So I think that's an interesting one.
Yeah, and similar, although we have the Medicare hospice benefit, the hospice benefit really doesn't cover the 24-hour care that many patients need that falls on families. And palliative care, we still don't have insurance coverage for the non-physician component of the care that's delivered. That's
very important to call that out. Thank you. Education and awareness, I think we both agree that there's a lot more that we can be doing out there, and talking, and certainly in veterinary medicine, is talking about the needs of geriatric patients and those that have been diagnosed with a life-limiting illness, to say that there is more that can be done, besides just reaching for euthanasia too quickly. And I should say that being a euthanasia expert, I appreciate when we do apply, euthanasia procedure when it is appropriate, but I love when we can leverage the best of veterinary medicine and provide more quality time and keep a patient, really thriving, even in face with that end of life event that's coming up before too long. And sometimes I think what happens with human hospice and with veterinary medicine is that we have so much more quality of time that we can actually have a patient lift out of what would be considered hospice time. Yeah. Anything that you'd like to say about the financial incentives to continued care before I move on?
Yeah, just that within modern human medicine, all of the financial incentives align with continuing care. Doctors are reimbursed more, hospitals are reimbursed more for chemotherapy, and so it is difficult sometimes to shift away from that.
Yeah, thank you. These are some of the shared challenges in One Health. The last one was just perceptions around death and changing the culture, the culture and embracing death rather than shying away from it. And in veterinary medicine, I certainly know that we can be having more conversations earlier. It's just a win-win-win all the way around, is what I would say there. So in closing here, One Health opportunities that Dr. Morrison and I discussed was the importance of talking openly with our families about what a good death looks like and doing everything we can to achieve that, ensuring that the dying process is well supported by the entire team and all caregivers, that we within human medicine and veterinary medicine should be collaborating more on research and getting publications out there that support both of our fields, and then attend cross-discipline education events, which I think is very special. And in veterinary medicine right now, we really just have the International Association for Animal Hospice and Palliative Care. That is the go-to for end-of-life continuing education, which I am sure in human medicine, you have many more than just one organization that we could go to as veterinarians and learn what you are all doing in human medicine. That would be my guess. So with that, Dr. Alvarez, I think we are ready to take some questions, if that's okay.